Hello, we are Team One, and we did our project on the ophthalmic implants for macular degeneration. My name is Matthew Casserly.
I'm Zach Siders.
And I'm Allison Smith. So the problem we're facing is age-related macular degeneration. So age-related macular degeneration, or AMD, is a disease that impairs and reduces a person's central line of vision by blood leaking into the macula. This leakage occurs due to pressure buildup in the blood vessels behind the eye. AMD impacts a person's vision by causing blurriness, cloudiness, floaters, and many more things. Depictions of what a person with AMD can potentially see is shown on the right. This is what would be seen if there is blood leaked into the macula. These impairments affect daily activities and ultimately a person's quality of life. Studies have also reported that AMD corresponds to a 39% increased risk of depression in its patients. AMD affects 11 million people in the United States and approximately 170 million people globally. These people suffer from either dry AMD, which is thinning of the macula, or wet AMD, which is growth of blood vessels and blood leakage. Dry AMD can progress into wet AMD, but if not diagnosed, but dry AMD is commonly asymptomatic. Blood leakage is a problem because when blood enters the retina, it can cause photoreceptor dissociation from the retinal pigment epithelium. Photoreceptors are responsible for converting light into electrical signals that are transmitted through the optic nerve into the brain for processing. If damaged, it can cause permanent vision complications. Therefore, annual eye exams are crucial, especially for anyone over the age of 55, which is when most AMD patients begin experiencing symptoms. Our proposed product is important for preserving an individual's central vision. Our design is targeted specifically toward wet AMD patients that experience active blood leakage and new blood vessel growth.
So we researched at least two existing solutions to help treat AMD, one being intravitreal injections, also known as anti-VEGF drugs, and the second being photodynamic therapy, which is just a combination between the injection and laser treatments. The table shown below is just a 2-year treatment cost analysis for AMD, and the highlighted column in green is just our intended cost for our implant, and these prices are for just one eye, but we may need it for both. Aside from this, our solution is preferable because it stops photoreceptor dissociation, and in addition to this, we want our potential solution to be long-lasting since the other two treatments we mentioned only last for no more than 2 months. And in terms of issues that may arise if our device is unimplantable, there would simply be a continuation of symptoms from AMD, so vision loss, blood vessel growth, etc.
Now let's talk about how we plan to solve this issue. So our approach consists of a single surgery drug reservoir that is implanted just above the macula. It releases 2 medications, the first being antibodies known as antivascular endothelial growth factors, or anti-VEGFs, and the second being adhesive peptide chains that promote photoreceptor adhesion to the retinal pigment epithelium. So the anti-VEGFs bind to and inhibit growth factors that promote blood vessel growth. This halts the unchecked blood vessel expansion that is responsible for obstructing a patient's central vision. The RGD peptide chains are tailored with specific receptors to adhere to both photoreceptor cells and retinal pigment epithelial layer, keeping them from separating. The device itself consists of a clear polymer casing that does not impede vision, with both drugs steadily diffusing through the release port and eventually getting refilled through the injection site after 6 months. Of the 0.3 milliliters of drug solution that the device can hold, 90% of that by volume will be anti-VEGF concentration, and the other 10% will be RGD peptide due to release mechanics that will be discussed shortly. So this is a quick video just to show how we plan to refill our implant. So it'll just be an intravitreal injection. The only difference between the actual injection and this video you're watching right now is that instead of being injected directly into the eye tissue, the refill of drugs would be injected directly into our implant. This allows for much less frequent injections for the patient, and they can be concentrated and sustainably released. So ranibizumab, which is the anti-VEGF we plan to use, has a shelf life of 3 years, and typical RGD peptide products have a shelf life of 6 to 8 months. So this is pretty much why we decided on a 6-month time period, so we could go the longest time without risking any efficacy sacrifice on the part of the drugs. So the main structure of the implant will be made of the PMMA, so the compartment that houses the drug mixture. This polymer is biocompatible and, more importantly, non-biodegradable, so the device will remain intact for the duration of the patient's lifetime and can continue to be refilled as needed. It is also mechanically strong enough to withstand the typical intraocular pressure of the eye, which ranges from 10 to 21 millimeters of mercury. A layer of silicone will be used to form the self-sealing injection site where the contents of the device can be refilled. Like PMMA, silicone is non-toxic and non-biodegradable, and its high elasticity allows the puncture site caused by the needle to close as the needle exits, keeping the implant sealed after multiple injections. Within the release port, there is a polyethyl oxide hydrogel network to control drug release through diffusion. The hydrogel system also has favorable biocompatible properties and can be manufactured with 2 different mesh sizes for the two drug products being released. The smaller of the 2 is the anti-VEGF molecules, and they have a mass of about 48 kilodaltons and require only a few nanometers of space to successfully diffuse, whereas the RGD peptide chains have a mass of a few hundred kilodaltons on average and therefore require larger mesh sizes. The size of the mesh is dependent on the PEO polymer concentration, which will be part of our testing discussed later. The faster diffusion of the anti-VEGFs, because they're smaller, is why we decided to go with a higher anti-VEGF concentration compared to the RGD peptides to make sure there's enough of both concentration to continuously release over the 6-month period. To sterilize the design, we determined that autoclaving treatment or pressurized steam would be the best method. It is relatively inexpensive and can be used for all materials just listed. Even the hydrogel, since the hydrogel being used is not temperature sensitive. Other sterilization techniques pose the risk of limiting the effectiveness of the mechanical properties of some materials. For example, gamma radiation would reduce silicone elasticity, which could lead to problems when we have subsequent injections. So our design also includes a surface coating of collagen following sterilization of the PMMA surface. The collagen induces cell adhesion to these surfaces, leading to greater integration of the device with the surrounding tissues. This integration will anchor the implant and prevent it from moving or drifting to other areas of the eye. We decided to use collagen because it provides a solid structural framework and has a high cell specificity, so it can bind to the cells that we want it to. And past studies have been conducted to show the effectiveness of collagen coating on cell adherence. So the obvious value of our design is that it prevents further vision loss and obstruction while actively improving the vision as well by removing blood vessel expansion. Additionally, the patient benefits from only needing 1 surgical operation with no removal or follow-up surgery required, just the intravitreal injections, which are less invasive by comparison. A comparable eye implant procedure in the first year of the drug mixture combined will cost around $17,000 today. And this seems like a lot at first, but it is still cheaper than alternative treatments, as mentioned previously. And the cost of the medicine itself is expected to decrease due to low cost competition in the future.
So here we researched some present solutions slash product implants that are already designed to combat and slow down the process of AMD. One of the first products that we researched was a telescope implant from the Center Sight Treatment Program company. And this device is just intended to improve distance and near vision AMD patients and provide central vision, while the other eye provides peripheral vision to the level it was before you had AMD, and it just won't completely correct your vision loss. The second main product we researched was the Argus 2 device from the Second Sight Medical Products Company that just provides rudimentary vision for blind patients. This device uses a small electronic chip that is surgically implanted onto the surface of the retina, and the patient just wears glasses containing a small video camera that wirelessly transmits images to that chip. And the last main competitor that we researched was the NR600 implant from the NanoRetina company, which just uses glasses that deliver infrared light to a chip. Like the Argus 2, the NR600 is positioned on the top of the retina. Some patients have reported improved visual experiences provided by the chips over time as they learn to interpret the novel light patterns provided by the chips, which just stimulate the healthy neurons on the surface of the retina. And just these devices, along with others, are still in the works, but these were the top 3 known implants used for the condition, and they're not as efficient as our current device since they won't have the adhesion peptides to stop dissociation from photoreceptors, as we mentioned before. And this is just a table that showcases our device compared to other treatments on the market. And as you can see, our device would incorporate all three of the necessary components to treat AMD.
So just a quick summary of the advantages and disadvantages of our device. The advantages include less frequent medical intervention because of the less frequent injections. The device prevents irreversible vision loss by keeping photoreceptors adhered to the retinal pigment epithelial layer. It also continuously prevents vision obstruction from blood vessels. It's cheaper compared to current alternatives. It's non-degradable and does not elicit any immune response, any major immune response from the cell. And it only requires one major surgery for implantation, and after that is relatively non-invasive. The disadvantages include it does not actually cure AMD entirely. It is still just treating the symptoms, and it cannot be used until a patient's condition progresses to the later stage of wet AMD. And the reservoir still depletes eventually and requires refilling after the 6-month period. And there's the potential for certain tissue responses during and after implantation. Basically, there's a chance that macrophage, lymphocyte, and fibroblast counts can increase.
So our engineering criteria will simply just encompass our outcomes and our benchmarking criteria and the necessary manufacturing for our product. So as shown in the first table, the given device must prohibit the continuation of AMD symptoms that occur in the macula. And in addition to this, the device must also prevent the association of photoreceptors from retinal neural epithelium, like we said before. The recommended device should also stabilize the release of ranibizumab growth inhibitor so that the user doesn't fully lose their vision. And the device should also help decrease/prevent blood vessel growth within the retina. These growths can cause deterioration in the middle layer of the macula. And lastly, we want the intended implant to be long-lasting as opposed to other treatments used for AMD. And similar to our functional requirements, our design objectives that we want to be able to solve, its operational needs and help determine what objectives will aid intended users in the future. And these are shown below. So in order to successfully measure the functional requirements and design objectives for the proposed device, the design specifications need to be met. So as addressed in the table, the ranibizumab must be released at a rate of at least 0.0017 milliliters per day. Also, the time for it has to be about 80 days to minimize the possibilities of macular degeneration. And the device must have a total of 75 microliters of adhesion peptides that will be released in order to adhere to the device. So most ocular implants are frequently made via thermal processing methods such as hot melt extrusion or injection molding, which is what our device would do. And during this process, the drug and polymer melts and blends together in an extruder. Once the polymer and drug are combined, they just pass through an additional extrusion or molding step in which heat and pressure form that final implant. And implant developers can tune the drug release to specific targets by doing this. Lastly, we want to select a partner with the knowledge of API polymer interactions and the correct equipment to develop and manufacture our product in a good manufacturing practice environment.
So now we're just going to go over our experimentation. So for our product, in order to determine the device's whether the device is effective, we're going to use optical coherence tomography, or OCT, which is an imaging technique that provides a cross-sectional area image of the retina. From these images, we can determine the presence of blood vessel leakage and the formation of new blood vessels, which should both be improved with our device. Second is intraocular pressure testing using a tonometer, which indicates if a person is experiencing ocular hypo or hypertension, which can be serious. Our device shouldn't cause any increase or decrease in intraocular pressure. And lastly would be a PEO concentration testing, which would allow us to determine the necessary hydrogel mesh sizes for our desired drug release rates. Next, for our animal testing, our device could be first used and performed on rodents, and these tests would simply be for safety and efficacy of our device due to the lack of a macula in smaller animals. Moving forward, non-primary humans, for example, chimpanzees, can be tested for our device's implantation, feasibility, and tissue responses, which can be monitored with OCT imaging. And one clinical trial that pertaining to AMD that is currently being performed is safety and tolerability of intravitreal injections such as ranibizumab, which would be important for our device specifications. And second, a company called Civismo performed safety and efficacy studies specific to ranibizumab, which reported patients experienced no permanent vision loss when measured by the best corrected visual acuity, the BVAC score. And this was the rationale between choosing ranizipam over other anti-VEGF drugs on the market. And these are our references. Thank you. Any questions?